Good day, everyone. We will be discussing sexual dysfunctions based on the DSM-5-DR, focusing on diagnostic criteria, major types of sexual dysfunctions, and how medicalization, gender, and culture influence diagnosis and understanding. Sexual dysfunctions are characterized by clinically significant disturbances in a person's ability to respond sexually or experience sexual pleasure. For diagnosis, symptoms must be present for at least 6 months, must cause clinically significant distress, and should not be better explained by medical conditions, substance use, or relational factors. The DSM-5-DR uses specifiers to further describe sexual dysfunctions. Onset may be lifelong or acquired. Context may be generalized, meaning it occurs in all situations, or situational, meaning it happens only in specific contexts. Severity is rated as mild, moderate, or severe based on symptom frequency and level of distress. Other specifiers include partner factors, relationship factors, individual vulnerability factors, cultural or religious factors, and medical factors. A sexual dysfunction should not be diagnosed if the problem is fully explained by a partner or relationship factors alone. These factors do not exclude diagnosis, but they also guide interpretation, and sexual dysfunctions are classified into major categories: disorders of sexual interest or desire, sexual arousal disorders, orgasmic disorders, sexual pain disorders, substance or medication-induced sexual dysfunction, and other specified or unspecified sexual dysfunction. Desire and arousal disorders include male hypoactive sexual desire disorder and female sexual interest or arousal disorder. These disorders are characterized by persistently low or absent sexual interest, thoughts, or arousal. In females, this may include reduced initiation of sexual activity, lack of pleasure during sexual encounters, or reduced response to sexual cues. Importantly, diagnosis is not based on low frequency alone. Clinicians must consider whether the symptoms cause significant distress and must take into account factors such as age, cultural background, relationship context, and life stressors. This distinction helps avoid labeling normal variations in desire as pathological. Sexual arousal disorders include erectile disorder, which involves marked difficulty in achieving or maintaining an erection or reduced erectile rigidity in most sexual encounters. This condition is often associated with distress, lowered self-esteem, and performance anxiety, highlighting both biological and psychological factors. Orgasmic disorders include delayed ejaculation, premature or early ejaculation, and female orgasmic disorder. These involve difficulties in the timing, frequency, or intensity of orgasm and must occur in most sexual encounters to meet diagnostic criteria. Sexual pain disorders, specifically genitopelvic pain or penetration disorder, involve persistent pain, fear, or muscle tension related to penetration, reflecting the interaction between physical sensations and psychological factors. Substance or medication-induced sexual dysfunction occurs when sexual difficulties begin during or shortly after substance use, medication exposure, or withdrawal. Common examples include antidepressants and alcohol, which may affect desire, arousal, or orgasm. For diagnosis, the symptoms must cause clinically significant distress and should not be better explained by other sexual dysfunctions. When symptoms cause distress but do not fully meet criteria for a specific disorder, other specified sexual dysfunction is used. In this case, the clinician records other specified sexual dysfunction followed by the specific reason, for example, sexual aversion. Unspecified sexual dysfunction is used when there is insufficient information or when the clinician chooses not to specify the reason.
Now let us move on to the medicalization of sexuality and sexual distress, wherein we're going to talk about the trends, pharmacological treatments, and as well as the psychological and behavioral therapies used in addressing the topic at hand. To start with, Let us establish that medicalization of sexual dysfunction involves viewing and treating sexual problems as medical conditions, often through pharmacological means like Viagra for men or ADI for women, alongside devices and therapies that address psychological, relational, and physical factors, reflecting a broader trend where pharmaceutical companies promote medical solutions for sexuality, sometimes overshadowing psychological approaches. Therapies range from medications and devices to sex therapy, counseling, and lifestyle changes, aiming to improve function and satisfaction, but also raising debates about defining normal sexuality versus medicalizing normal variations. In this age, medicalization trends include increased pharmaceutical focus and biomedicalization. Increased pharmaceutical focus involves the introduction of drugs like sildenafil or Viagra, for example, for erectile dysfunction marked a significant shift, leading to broader promotion of prescription for sexual issues in both men and women, while biomedicalization involves technology and corporate efforts focus on turning sexual health into marketable risks and solutions, often through self surveillance and drugs. Now, these trends promote a debate on normalcy, wherein some argue these medicalizes normal sexual responses, creating anxiety and promoting interventions when some dysfunctions might not be seen as problems by some individuals.
Therapies for sexual dysfunction include pharmacological treatments for both men and women to address erectile dysfunction in men and low desire or arousal for women. They use medications such as Viagra, Cialis, and hormone therapy as well. Another approach is the use of mechanical aids such as penile implants, vacuum devices, and vibrators. Another approach for therapy for sexual dysfunction includes psychological and behavioral therapies such as sex therapy and counseling to address psychological barriers, relationship issues, and performance anxiety. Cognitive behavioral therapy to help change negative thought patterns and behaviors related to sex, and mindfulness and sensate focus to introduce techniques to improve awareness and pleasure. Another approach would be the lifestyle and physical change, which include pelvic floor exercises or Kegels, healthy diet, exercise, and managing underlying conditions such as diabetes and heart disease. Key considerations. A combined approach is often the most effective treatment as it involves a combination of medical and psychological therapies, acknowledging complex causes for every client. The underlying causes is also one of the key things to be considered, as treatment must address root causes, which can be physical or psychological as well.
Gender, culture, and power in sexual dysfunction diagnosis. This part will give an overview of how these factors have influenced diagnosis over the years. Let's first start with looking at history through the lens of gender, culture, and power as factors when it comes to sexual dysfunction diagnosis. Let's first start with gender as a factor. Back in the 19th century, hysteria was the go-to diagnosis for women who were mysterious or unmanageable. So if a woman didn't fit the Victorian ideal of a passive domestic woman, then they are seen as having a lack of womanly duties being marriage and childbearing. Now, for the treatment, the doctors often perform pelvic massages to induce paroxysm or orgasm as a medical cure for irritability or anxiety. This gives us an idea that gender really is a factor when it comes to sexual diagnosis because of certain stigmas. Now, through the lens of culture, some have this sex-negative framework. This is basically a mindset where they see sex as only linked to procreation, and they enforce this with strict norms. Now, in cultures like this, when one expresses that they lack interest when it comes to sex or that they're having challenges being aroused, they would actually see this act as a failure to adhere to social scripts rather than a biological or a psychological issue. Back then, power was linked to a male's ability to have an erection. In the mid 20th century, the diagnosis erectile dysfunction was considered as purely biological, completely missing the possibility of the cause being psychological strain from underperforming. So, this has been an issue and it has actually been raised throughout the years, and they are also addressed. You will see the changes and how it affects modern psychology today in the next slides.
Today, in the DSM-5-DR, sexual dysfunctions are diagnosed in a more structured way compared to before. The DSM emphasizes that a sexual difficulty becomes a disorder when it is persistent and causes clinically significant distress. Clinicians are also expected to consider possible medical causes, medication or substance effects, other mental health conditions, and the person's relationship context before making a diagnosis. For gender, DSM-5-DR focuses more on symptom patterns and distress rather than gender stereotypes about what sexuality should look like. A good example is female sexual interest or arousal. For culture, DSM-5-DR assessment also considers socio-cultural influences that shape sexual expectations and distress. This meant for power, DSM-5-DR diagnoses remain individual categories, but clinicians are still expected to assess relationship context because it can influence symptoms and distress. Sexual difficulties may be shaped by pressure, coercion, inequality, or lack of autonomy, factors that affect emotional safety and sexual response. So a symptom like low desire may not be simply a personal deficit, but something strongly linked to the relational environment. So overall, the biggest shift from the past to the present is this. Sexual dysfunction diagnosis in the DSM today is still symptom-based and individual, but it is also more careful about context. Gender expectations, cultural meanings, and power dynamics can shape distress and sexual functioning.
Good day! We will be examining eating disorders through a critical advanced lens. While the DSM-5 outlines several specific diagnostic categories for this advanced critic, our group will focus on the underlying mechanisms of identity, control, and trauma that bridge this diagnosis. We believe that to truly understand the pathology, we must move beyond simple diagnostic checklists and look at the functional purpose the disorder serves for the individual. To ground our discussion in lived experience, we will be showing a series of interviews with individuals navigating eating disorders. These videos highlight the ED voice and the complex relationship between the self and the illness. As you watch, we encourage you to look past the physical symptoms and consider our graduate critic, whose norms define dysfunction.
Eating disorders are often misunderstood as concerns limited to vanity or body image. This view overlooks the reality that eating disorders involve complex psychological, biological, and social processes that extend far beyond appearance. In clinical and academic context, eating disorders are better understood as conditions that serve important psychological functions for the individual. Behaviors related to food, weight, and control often emerge as responses to emotional distress, internal conflict, or difficulties in self-regulation. One way to understand this complexity is through the biopsychosocial spiritual model. From a biological perspective, genetic vulnerability, neurobiological factors, and disruptions in hunger and satiety can increase susceptibility to disordered eating patterns. Psychologically, individuals with eating disorders commonly present with perfectionism, anxiety, depressive symptoms, and challenges in emotional regulation. Disordered eating may function as coping strategy, providing a temporary sense of control, predictability, or relief from distress. Social factors also play a significant role. Cultural body ideals, media exposure, family expectation, and peer dynamics can shape belief about self-worth and reinforce disordered eating behaviors. In addition, The spiritual dimension highlights concerns related to identity, meaning, and connection. For some individuals, eating disorders reflect a deeper sense of disconnection from self or others, where control over the body becomes a way to manage this loss of meaning. Taken together, this perspective allows eating disorder to be understood not as superficial concern, but as complex condition embedded within an individual's lived experience.
Now, how does control and trauma links with body image and eating disorders? Well, eating disorders are often misunderstood as disorders of vanity or body dissatisfaction. However, clinical and research evidence shows that they function as maladaptive coping mechanism in response to trauma, emotional overwhelm, and loss of control. So rather than focusing on weight or appearance, this framework views eating disorders as attempts to manage psychological distress, especially in individuals with trauma histories such as PTSD. But what exactly is the role of trauma in eating disorders? Trauma disrupts a person's sense of safety, predictability, and control. So in response, eating disorder behaviors can temporarily restore a sense of control and emotional containment. Although the DSM-5 classifies eating disorders separately from PTSD, the research shows high comorbidity. To further explain this neurologically, trauma actually changes how the brain functions. When a person experiences trauma, the body's stress system becomes overactive. Cortisol levels stay elevated, the amygdala, which is the brain threat detector, becomes more reactive. And the prefrontal cortex, which helps us regulate emotions and make rational decisions, becomes less effective. Because of these changes, eating disorder behaviors can feel relieving at first, like restricting food, binge eating, or purging may temporarily reduce anxiety, numb overwhelming emotion, or create a sense of control when everything else feels so chaotic. The brain learns that these behaviors provide a short-term relief, so they become reinforced over time. This is why, in many cases, trauma actually comes first, and the eating disorder develops as a response later on. Clinically, many individuals with eating disorder report history of emotional neglect, abuse, and chronic invalidation. Concerns about weight and body image often appear later and are not really the original cause, but rather a secondary explanation for a deeper emotional pain. For example, in the Philippine context, this pattern is often intensified by cultural values such as hiya, emotional restraint, and a strong family hierarchy. Mental health struggles are frequently minimized, and the people are taught to endure the stress quietly. As a result, emotions are suppressed instead of expressed. Over time, this internalization of distress, combined with the trauma-related brain changes, strengthen eating disorder behavior as a private way of coping. Because of this, effective treatment must go beyond control or weight restoration. If trauma is not addressed, recovery is often incomplete. So ultimately, eating disorders should be understood as a trauma-driven survival adaptation where control replaces safety. A trauma-informed approach allows for more compassionate, accurate, and effective care, and it creates a stronger foundation for a sustainable recovery.
Let's look at how an eating disorder moves from behavior to an identity. In advanced cases, patients describe an ED voice. This isn't a medical hallucination. It is a deeply ingrained internal dialogue that acts like a secondary personality. Think of it as a toxic coach. It rewards the person for disordered behaviors and punishes them for eating, slowly becoming the main way the person talks to themselves. At this level of study, we realize the disorder isn't just about food. It's about who the person thinks they are. To treat this, we have to understand if the person wants to change. We use two key terms here. Egosyntonic, common in anorexia, the symptoms feel right to the patient. They see their restriction as a strength or a source of pride. Because the disorder matches their self-image, they often resist treatment because giving up the illness feels like losing their best quality. Ego dystonic, common in bulimia. The symptoms feel wrong. The patient feels intense shame or guilt because the behavior, like purging, goes against who they want to be. This distress actually makes them more likely to seek help because they want the behavior to stop. So, what is our role as future psychologists? We have to ask, whose norms define dysfunction? If a patient feels powerful through their disorder, simply telling them to eat more won't work. When we treat an egosyntonic disorder, we are essentially asking the patient to kill off a part of their identity. If we don't help them build a new healthy self-image to replace the ED voice, they are left with an identity void. This is why recovery is so difficult. It requires building a whole new person, not just changing a diet. Next, we will look at how these internal struggles are judged by society and the impulse control labels.
For this part of the presentation, I want to focus on the question, whose norms prevail when we diagnose eating disorders? Most eating disorder diagnostic criteria were developed in Western countries, particularly in the United States and Europe. This criteria emphasize fear of weight gain, body dissatisfaction, and pursuit of thinness. This idea reflects Western cultural values where thinness is often linked to health, discipline, and success. The problem is that these values are treated as if it is universal, even though they are culturally specific. From the very beginning, our understanding of what counts as eating disorder is shaped by Western norms. Cultural specificity. Eating disorders exist all over the world, but research shows that they do not always look the same across cultures. For example, in Western settings, a person with anorexia often explains food restriction by saying they are afraid of gaining weight or unhappy with their body. This fits the diagnostic criteria exactly and very clearly. However, studies in several Asian countries have documented patients who meet medical and behavioral criteria for anorexia, such as severe restriction, weight loss, physical health risks, but they do not report fear of becoming fat. Instead, these individuals explain their eating behavior by saying that the food is the one that is causing them stomach pain, bloating, or physical discomfort, or simply they do have no appetite. This behavior is the same, dangerous food restriction, but the explanation is very different. This difference is shaped by culture, not by the severity of the illness. If clinicians only listened for Western body image, these cases may be missed or misdiagnosed despite of the clear medical risk. Moving on, eating disorders are also frequently overlooked in people who do not fit the stereotypical image of someone with an eating disorder. For example, a person in a larger body may be skipping meals, restricting food intake, and experiencing intense anxiety around eating. Instead of being assessed, people say, "Oh, she's losing weight," or told that they are improving their health. However, if a thin person engaged in the same exact behavior, likely people would pose a concern. Also in men are often undiagnosed. Eating disorder in men is frequently dismissed as also fitness goals or discipline, in which it also delays the diagnosis and treatment. Research also shows that people from racial and ethnic minority groups experience eating disorder, but are less likely to be identified or referred to because of bias, stigma, and lack of access. These examples show that diagnosis is not only influenced by just the symptoms, but by also social expectation about who is supposed to have eating disorder. Lastly, we need to consider the role of colonial influence in mental health. Western psychiatry has become the global standard through historical, academic, and healthcare system. As a result, Western models of mental illness are often applied to populations with very different beliefs about food, body, and health. In some cultures, eating less may be associated with the religion, moral discipline, and family expectations. If harmful restriction develop in this context, it may not be immediately recognized as a disorder. When Western countries' diagnostic frameworks are applied without cultural understanding, we risk two outcomes. One, missing eating disorder altogether, or misinterpreting cultural practices as a pathology. So, when we ask, whose norms prevail? We are asking whether our diagnostic system allows us to accurately and ethically understand eating disorders across different cultural contexts. Eating disorders are global, but our diagnostic framework remains largely Western, and it affects who is seen, who is diagnosed, and treated.
Building on the earlier discussion of trauma, identity, and biopsychosocial factors, these slides highlight the clinical limitations of symptom-focused treatment in eating disorders. From a clinical psychology perspective, symptom reduction alone is often insufficient. Behavior-focused talk therapy may lead to short-term improvement, but it frequently fails to produce sustained recovery when the underlying function of the eating disorder remains unaddressed. Patients may demonstrate behavioral compliance or cognitive insights without internal change, meaning that the eating disorder continues to operate at an emotional and embodied level. This explains why insight alone is not enough to support lasting recovery. Understanding the problem intellectually does not override conditioned emotional responses or trauma-related regulation patterns. Clinically, surface-level interventions increase the risks of treatment resistance, cyclical relapse, and the mislabeling of patients as non-compliant or unmotivated, when the underlying issue is often treatment misalignment. As a result, treatment that targets behaviors without examining their function allows the eating disorder to remain adaptive and entrenched. Given these limitations, effective care requires function-based assessment. Clinicians must assess what the eating disorder does for the patient, such as providing emotional regulation, identity stability, or a sense of control related to trauma. Treatment planning should account for trauma history, identity attachment, and emotional regulation needs, rather than focusing solely on symptom elimination. This has important implications for treatment planning. Integrative approaches support deeper change by addressing emotional regulation, identity reconstruction, and embodied experience. Trauma-informed frameworks reduce relapse and disengagement by aligning intervention with the psychological mechanisms that maintains the disorder. Sustainable recovery depends on interventions that address the psychological function of the disorder, not just the reduction of the symptoms.
To conclude our section, we've seen how eating disorders often function as a maladaptive shield, a way for individuals to reclaim a sense of control or identity in the face of trauma. As clinicians, we must remember that treating the eating behavior is only the first step. The true challenge lies in addressing the egocentric nature of the disorder and the identity void that recovery can leave behind. By shifting our focus from weight to function, we can better support patients in disentangling their self-worth from their symptoms. This intersection of identity and coping is not unique to eating disorders. It also plays a significant role in how individuals navigate substance use, which we will be exploring next. I will now turn the floor over to the substance use disorder to discuss addiction as a disease, a choice, and a method of coping.
Good morning, good afternoon, or good evening, depending on the time you are viewing this audio report. So, for this portion of the discussion, we will focus on substance use disorder, and I would like to briefly introduce myself. I am Miss Jacob, and I'll be discussing the preliminaries of this topic. So basically, according to DSM-5, substance-related disorders are classified not based on whether a substance is legal or illegal, but rather on how its use affects a person's physical and psychological functioning. As a result, substance use disorder are defined by maladaptive pattern of substance use that leads to significant distress or impairment in functioning. So to receive a diagnosis, a person must exhibit at least 2 symptoms within 1 year period. Now, just to clarify, and I think that this one is important, we have to understand that not everyone who uses substance is automatically diagnosed with substance use disorder, because the DSM-5 clearly specifies that a diagnosis is made only when at least two symptoms appear within 1 year period indicating impaired control, distress, or even dysfunction. Moving forward, DSM-5 further identifies two main categories of substance-related disorder, and that refers to substance-induced disorders and substance use disorder. Now, let's begin with substance-induced disorders. These occurs when abnormal behavior are directly caused by the effects of the substance. The most common examples are intoxication and withdrawal. Now, allow me to define intoxication. In layman's term, intoxication refers to the feeling of being high, and its effects may vary depending on the substance used, the amount taken, and the individual's tolerance of taking that particular substance. On the other hand, withdrawal occurs when the substance use is abruptly stopped after prolonged use, resulting in physical and psychological symptoms. For illustration purposes, consider this example. Here we have Pedro. Pedro first consumed alcohol at the age of 15. After drinking, he felt dizzy and lost his balance and coordination. This is a classic example of intoxication. Fast forward several years, let's say after a decade, Pedro has been consuming alcohol on a daily basis for a decade, and when he sought professional help and was advised to stop drinking, he experienced withdrawal symptoms such as shaky hands, excessive salivation, and agitation. Now, at this point, it's important for us to understand why we have to distinguish intoxication and withdrawal, because these two stages require different clinical approaches. Intoxication often focuses on immediate safety and symptoms management. On the other hand, withdrawal symptoms may require medical monitoring and structured treatment to prevent complications. Moving forward, let's talk about the general overview of substances in their primary effects. So this classification is very basic, but it provides a helpful foundation, because if you're going to check or refer to DSM-5, you'll find many more specific examples listed there. But for the sake of brief discussion, let's just focus to the most common ones, and that refers to depressants, stimulants, depressants, stimulants, and hallucinogens. Now, let me discuss depressants. Depressants are often referred as downers because they slow down brain activity and central nervous system functioning. On the other hand, stimulants are commonly stimulants are commonly referred as uppers because they increase alertness, energy, and brain activity. And last but not the least, we have hallucinogens from the word itself, hallucinations. So basically, hallucinogens induce hallucinations or altered perception, affecting how a person experiences reality. Now, moving forward, I think this one is a common concern and a major misconception in a society. This refers to whether substance use disorder is a disease or simply a choice. And the answer actually is neither, and this is backed up by research. Chess. The term disease is not entirely appropriate because it mainly refers to the conditions which condition with a clear biological pathology. On the other hand, the term disorder is more accurate because substance use disrupts a person's psychological, behavioral, and social functioning. As to the issue of whether it is a choice, we have to understand that substance use may initially involve personal choice. However, once dependence develops, the individual gradually loses control and behavior becomes driven by intense cravings and withdrawal symptoms rather than free will. That's why if you're going to check what is indicated in the slide, it says that as dependence develop, an individual's ability to choose freely becomes significantly impaired. This loss of control is a key reason why DSM classifies substance use as a disorder rather viewing it as a morally failing or simply a matter of choice. So I hope we are able to make a stand regarding this issue because there are recent researches that could back up the claim that none of these two options would affect substance use disorder. It's not a disease and it's not simply a matter of choice.
Good morning, everyone. This is Trixie, and I'll be discussing about addiction as coping. So the first question is, what is addiction? Addiction is a chronic condition in which a person compulsively uses a substance or engages in a behavior despite harmful consequences and has difficulty stopping even when they want to. Some key features of addiction include craving. This is the strong urge or desire to use the substance or do the behavior. We also have loss of control. This is when the person uses more or longer than intended. Compulsion, this is the repeated use despite negative effects on health, relationships, work, or life. We also have tolerance. This is when the person needs more to get the same effect. So this is common for many addictions. And of course, withdrawal. So this is when the person experiences physical or emotional distress when stopping. And this is common for many addictions as well. Now we move on to the next slide. Substance choice is rarely random. In the context of addiction as coping, this means that people tend to gravitate toward substances that serve a specific psychological or emotional function for them. The substance is chosen often unconsciously because it helps them cope with something they are struggling to manage in other ways, or even in their own ways. Many people use substances not primarily to just get high, but to regulate something internal. This includes maybe emotional pain, anxiety, fear, depression, or trauma, and also maybe social discomfort. So the substance becomes a tool for self-regulation when healthier coping skills feel unavailable or ineffective. So another thing about substance choice not being random is because different substances produce different effects on people with their emotions. So they tend to choose substances that match their unmet needs. So with that being said, different drugs means different psychological needs. This idea comes from understanding addiction as a form of self-medication. People tend to use substances that create the specific mental or emotional effects they are lacking or trying to escape. To further support that, I'll be giving some examples of how various drugs meet different psychological needs. Number one example is alcohol. This is a form of depressant. Alcohol can relieve anxiety. It can reduce fear and self-consciousness, emotional numbing, and it can also reduce stress. Alcohol being a depressant, it has the capability to slow down the nervous system, making overwhelming emotions feel quieter and more manageable. They are often used by people with social anxiety, chronic stress, or people with trauma or hypervigilance. Next one is cannabis. Cannabis can give relaxation, can be a sleep support for emotional distancing, and stress reduction. Cannabis can dampen emotional intensity and slow racing thoughts. This is frequently used by people dealing with anxiety, insomnia, or people with overwhelming emotions, or some who has difficulty switching off. We also have opioids. So this includes heroin, morphine, or painkillers. Opioids can give comfort and emotional warmth. It can be a form of relief from emotional and physical pain, or it can give the person a sense of safety and well-being. Opioids mimic natural endorphins, creating deep emotional soothing. It is often associated with trauma and grief, chronic emotional pain, and feelings of emptiness or abandonment. Lastly, we have stimulants, and this includes cocaine, methamphetamine, and amphetamines. So stimulants can give energy and motivation, confidence and self-esteem, and it can boost focus and alertness. Stimulants increase dopamine and norepinephrine, which can temporarily make people feel powerful, capable, and maybe alive. And this is common among individuals who experience low mood or depression, fatigue or burnout, and feelings of inadequacy. All of those examples prove that different drugs really meet different psychological needs. This is by altering brain chemistry in ways that temporarily relieves distress and enhance functioning or provide emotional escape. On to the next slide is trauma histories. So trauma histories is common across substance type. This means that regardless of which drug a person uses, a significant number of people with substance use disorders have experienced trauma. and that trauma plays a central role in the development and maintenance of addiction. Trauma is defined by its impact, not just the event itself. Substance type varies, but trauma is a common thread. Addiction often represents an attempt to survive and cope with unresolved trauma, using whatever substance is available or effective at that time. In short, people may use different drugs, but many are responding to the same underlying wound, which is trauma. Now, people may have the ability or capacity to stop or remove the substance from their bodies, but however, it causes destabilization. Stopping drug use without addressing what the substance is actually doing for the person often leads to emotional, psychological, and functional collapse rather than recovery. In the past slides that I have discussed, for many people with addiction, the substance is not just harmful, but it's also a form of stabilizer for them. So it's a way for them to regulate their emotions, it's their way of calming their anxiety, it's a tool for them to manage their trauma, and a source of energy, focus, or motivation. Now, what happens when it's removed? What happens when destabilization occurs? Number one is loss of emotional regulation. Emotions may feel intense and unmanageable, chaotic or overwhelming, and it's rapidly shifting. Next is return of underlying symptoms. The original issues the substance was masking often resurface. The person may have trauma flashbacks, anxiety or panic, depression or emptiness, insomnia, and poor concentration. Identity and routine disruption includes a sense of emptiness, loss of purpose, and disorientation. Neurobiological imbalance may occur as well. Long-term substance use changes brain chemistry, so removing the substance leaves the brain temporarily unable to self-regulate, leading to dysphoria, irritability, cravings, and stress hypersensitivity. So with that being said, without a replacement coping system, the brain remembers, the substance worked, so I might as well go back to using it. So under stress, returning to use feels like the only way to restore balance. To end my discussion, people use different substances, but often for the same reason. This is to survive emotional pain. Recovery works when we understand why the substance mattered and help build safer ways to meet those same needs. Thank you so much for listening. I hope you gained knowledge from what I have discussed. And don't forget, your mental health matters. You are valued, loved, and not alone. Take care of yourself. You deserve it.
Hi, I'm Steffi, and I'm going to discuss harm reduction versus abstinence. In clinical psychology, once a diagnosis of substance use disorder is made using the DSM-5 criteria, the next hurdle is determining the treatment goal. Historically, the field has been divided into two primary camps, abstinence and harm reduction. While one demands the total cessation of use, the other focuses on meeting the individual where they are to reduce the immediate dangers associated with their behavior. The abstinence model is the traditional gold standard in many recovery settings. It posits that for an individual with a severe SUD, any use is a trigger for a return to disordered patterns. It provides a clear boundary for the patient. However, the DSM-5 recognizes that SUD exists on a spectrum from mild to severe. For some, the all-or-nothing nature of abstinence can lead to a sense of shame or a total abandonment of treatment if a single slip-up occurs. The most significant shift in the DSM-5 was the elimination of the binary abuse versus dependence distinction in favor of a severity spectrum. By counting the 11 criteria, we can now classify a disorder as mild, moderate, or severe. This isn't just paperwork, it dictates a clinical strategy. For someone with mild disorder, perhaps experiencing cravings and using in risky situations, harm reduction strategies like moderation management or controlled use can be highly effective early interventions. However, as the diagnosis moves toward the severe end of the spectrum, where physiological withdrawal and total loss of control are present, abstinence often becomes a medical necessity to ensure the patient's safety and long-term stability. In contrast to abstinence, harm reduction is a public health philosophy. It acknowledges that for various reasons, some individuals are not able or willing to stop using substances immediately. Rather than denying them care, harm reduction focuses on safety. In the context of the DSM-5, this approach aims to reduce the severity of the diagnostic criteria, such as social or occupational impairment, even if the use criterion is still technically met. It prioritizes keeping the individual alive and connected to healthcare systems. Let's see a comparative analysis. When we compare two, we see a shift in the definition of success. Abstinence measures success by the absence of the substance. Harm reduction measures success by the presence of health and social functioning. While abstinence is often the ideal long-term outcome for severe DSM-5 cases, harm reduction serves as a vital bridge, particularly for those in the pre-contemplation stage of change who aren't ready to commit to a lifetime sobriety. Modern abnormal psychology increasingly views these as not enemies, but as tools in a toolbox. By integrating both, clinicians can provide a continuum of care, whether the goal is a total remission of symptoms, as defined by the DSM-5, or simply reducing the risk of a fatal overdose. The focus remains on the dignity and health of an individual. Even when treatment model shifts, stigma around certain substances remains. Thank you.
Hi, my name is Hannah. Stigma in substance use disorders refers to the process of labeling individuals, attaching negative stereotypes, and then justifying discrimination. According to Navid and colleagues, substance use disorders have historically been viewed through a moral lens, where individuals are blamed for their condition rather than understood in context. Even today, people with substance use disorders are often seen as irresponsible or lacking self-control. This stigma doesn't just affect public opinion, it directly affects whether individuals seek treatment and how they are treated when they do. Addiction was understood as a moral failing, a result of poor choices or weak character. This justified punishment rather than care. The medical or disease model was introduced to reduce blame by framing addiction as a chronic brain disorder. However, research shows that medicalization does not fully eliminate stigma. Instead, it can shift stigma from moral blame to perceptions that individuals are permanently damaged or incapable of self-control. So even when addiction is treated as a disease, moral judgment often remains embedded in how society responds. Stigma is not applied equally across substances. Drugs like crack cocaine are heavily criminalized and moralized, while substances like alcohol or prescription opioids are more likely to be medicalized. This difference is not about the pharmacology of the drug, it's about social power. Research shows that race, socioeconomic status, and legality strongly influence whether someone is viewed as a patient deserving care or a criminal deserving punishment. In this sense, stigma reflects broader social inequalities, not just individual behavior. Stigma has real consequences. Individuals who internalize shame are less likely to seek help and more likely to drop out of treatment. On a policy level, stigma supports punitive responses and abstinence-only models while undermining harm reduction approaches. Ultimately, stigma doesn't just describe substance use disorders, it actively shapes outcomes. If stigma persists even when addiction is medicalized, whose moral values are actually defining what counts as recovery or normal behavior?